Is private healthcare better for general practice? In this episode, myself and Andy are continuing some of the previous news stories we've heard about changes that have happened within general practice and debating this topic from our perspectives, and absolutely keen to hear what you're thinking about this as well, as we talk about whether or not private healthcare can work with UK general practice and the NHS. So let's tech enhance your primary care and learning. GP learners, and welcome to this episode with myself and Andy doing something slightly different to normal. We're having a little bit of a debate, aren't we, Andy?
Yeah, we're going to have a bit of a chat about private healthcare because I'm actually quite curious, Gandhi, to know what you think about it, really. And I guess this comes off the back of two recent episodes that we did. So we did the BMA's new guidance for practice to deal with the demands placed on them from private healthcare, and that was a really interesting episode. And then last week we looked at Centene's departure from UK general practice provision. So there was that interesting story with Pulse reporting on a story in the Financial Times about Centene, who are a large multinational American healthcare company who had acquired, I think, 53 practices from 80 medics in London to make them the largest provider of GP services in the UK, with 640,000 patients and over 60 surgeries back in 2021. And actually, they decided 30th of August to announce that they are going to sell that interest in UK general practice, all 60 practices. They think they might get about £51.2 million for that interest, but they want to divest of that interest. And they also selling their UK private hospital and clinic business, Circle Health, and had already agreed to sell that earlier in the year to a Middle Eastern company for, I think it said, about 1.2 billion. So interesting departure of a big provider of private healthcare in the UK, with some discussion around the fact that it appears that they couldn't make a profit, that they couldn't make it worth their while to deliver that. So that was an interesting discussion. And, as we came to the end of that, I think we were both really wondering what does the other, really think about, private healthcare. We've been around for a while. So interesting to have that conversation, Gandhi.
Yeah, and I think important to remember a couple of different aspects of general practice as well. So general practice itself is technically a private provider of healthcare to the NHS. So majority of practices are independent partnerships between individuals who are partners, who run a business of providing healthcare to the NHS by providing services. And that's effectively what the GMS, so General Medical Services contract is. That's what's negotiated by the GPC, which is part of the BMA. And we've talked numerous times around these contracts and stuff. And obviously, hopefully you've seen some of that stuff in the past if you're joining us. But effectively, it's a contract that's provided by a group of partners or potentially now companies, because that has started to happen in some places, providing those medical services to a population under the terms of typically GMS contract. Pretty much PMS is heading on its way out, and some places being an APMS, which is like a bolt-on additional kind of contract to manage particularly short-term contracts, caretaker contracts, that kind of stuff and things. So effectively, general practice is private industry, but it's very much ingrained within the principles and the concept of the NHS, and obviously free at the point of access. And then it raises that question of how well it delivers that. And if you go back through the history books, pretty well up until maybe the past few years, when obviously a lot of the challenges facing the resources around general practice, the demand and all that kind of stuff have massively bitten into it, causing an impact. And it then raises that question of supply, demand, and access. And we seem to always talk about access, don't we, Andy? But this is more about timely access potentially provided by an alternative source, which is traditional private healthcare.
Yeah, I think you've given a good overview of things there, Gandhi. And I guess whilst general practice, the traditional model is, privately owned, small partnerships, they're not limited companies, so they don't have shareholders. We're not talking about, distant shareholders with a shareholder interest, in increasing the value of that company or extracting value in dividends, for example, that we might think about with a limited company type structure, or a structure limited by shares. These are partners who are generally healthcare professionals who are kind of living close to, working with, the communities that they're serving, and very much at the mercy of the NHS, in terms of having that one contract where most of the income comes from, and actually kind of have to jump if the NHS say jump, to a certain
Yeah.
degree. That larger companies, might have other options. So I think they are quite, different beasts, the more recent, larger
Hmm.
private companies. Although people may have made the argument that they bring in, additional investment potentially
Hmm.
into the sector. They come with shareholders who, they don't just want, dividends. They can invest in the expectation of future profits. And actually, maybe we do need or did need, more infrastructure build,
Hmm.
staff training, recruiting, in order to improve services, then and further down the line. Maybe we did need investment. Yeah, so it's an interesting topic, isn't it? But just back to Centene and their exit, and why we did talk about this a little bit last time, but
Hmm.
why do you think they found it difficult to make money? Because just interesting that they came in, obviously, they made an investment, invested a lot of time as well as money, in acquiring these practices, and they've exited. Why do you think they found it hard?
I mean, the cynic would probably say that the contracts currently offered for general practice just don't allow you to make enough profit to make it manageable. It's one of the things we've talked about on numerous occasions, that is actually there's enough resource to help general practice actually function. I think the difference comes is when you are having that within a company structure whereby, like you say, you've got other things to pay, so investors, that kind of stuff. There needs to be a profit margin that allows that to be sustainable. Whereas with traditional general practice, it's often led by partners, and the profit is their overall income. So they're kind of contributing the work to the workforce by doing that, whereas the investors aren't. They're still expecting a payout in a sense, and maybe that's one of the challenges that then makes it not as profitable as people think it can be, because you still have to pay all these staff and things to do that, unless you cut back on those resources and find ways to make it more cost effective, because it's based on, as we know, a capitation based model. How much you get paid for running general practice based on the number of patients, a certain amount per that number of patients, and you have to deliver the services, everything, for that amount of money. It's not transactional like a shop,
Yeah.
going in and you buy something, and actually if there's more or less demand, you can adjust the prices of those, and that has an impact on your profit versus your demand and everything else as a result of it. General practice, that doesn't work. It is all the time, constant, non-ending supply.
Yeah. I mean, I guess what you're saying is basically, there's a contract to provide for the needs of the population,
Hmm.
and the value of that contract doesn't increase if the needs increase.
Hmm.
Actually, the provider carries that risk.
Hmm.
It's not like if there's an additional appointment, you can claim for the additional appointment. You're just paid on a population
Hmm.
basis, which a lot of people perhaps don't, understand. A lot of hospital services actually are per item of service, whereas
Hmm.
so if you do a hip replacement, you get paid for that hip replacement. Whereas in general practice, it's a capitation based system, so you get paid
Hmm.
per head per year, and you have to deliver as many appointments, in general practice, or services in general practice, as that patient needs. There are some enhanced services that pay per item of service, but
Yeah.
largely for the majority of the funding, it's just about a capitation payment. But yeah, I was just sort of backing up, really, just thinking about why they may have needed to exit, because I guess it's maybe some people may look from outside at general practice or at healthcare and sort of think, oh, surely there's economies of scale there. And I'm sure they must have thought this. And
Hmm.
actually, I've often thought this as well over the years.
We both
But
have. I mean, we often talk about
yeah,
economies of scale that can be made when you do particular projects or services and that kind of stuff, and have seen some benefit of that happening, for example, in terms of networks and other kind of things. But yeah, carry on.
yeah, I would say, but I think this might demonstrate that there are limits there, particularly in general practice and in healthcare,
Hmm.
probably more generally as well. And I'll say it again because I said it last time, and I quite like the way it sounded. But maybe actually general practice is a bit more like your hairdressers, than it is Tesco. Because actually at the end of the day, when it comes to delivering the service, it's normally a fairly highly paid person who is dealing with a patient one on
Hmm.
one, real time, a doctor, nurse, a pharmacist, somebody else who has to spend time, might be on the phone, might be on video, might be in
Hmm.
person, but they have to spend their time looking after that person one-on-one. And actually, very difficult to scale that. Most of the
Hmm.
costs in healthcare, I know, it's the staff costs,
Yeah.
and actually very difficult to scale that. You might say, well, actually, maybe we need fewer managers, fewer admin staff, if we can get some economies of scale in those areas of the business. And I'm sure
Hmm.
that's what they tried to do, and maybe were failing or struggling to do when push came to shove. And maybe there is some money to be saved there. But also, if you're a big organization, you've got head office costs. Um, they might be willing to subsidize
Hmm.
an entry into a new market for a period of time, for a number of years, to get the market share. But ultimately, I think a private company needs to see that it's going to be profitable in the long
Hmm.
term after they've extracted the costs they need for for head office. They've got yeah, there's fewer fewer managers or admin staff, but there's a big chief executive or a board. There are shareholders. There are large pieces of infrastructure across a big multinational organization that do need paying for by the the coal face activity. So I guess maybe they found that the whole thing doesn't work. But yeah, it's been interesting to watch.
It has. And I guess it raises the question of, can private healthcare actually work within general practice in the UK? So important to note, other healthcare systems work often very differently to how we do things in the UK. And there was a recent review of the Commonwealth Health things, and if you go back 10 years, actually, UK was number one in pretty much almost every part, apart from cancer care, if I remember rightly. And that was about 10 years ago. The more recent one puts the UK at number 4. I believe Australia came out number 1. No, sorry, Norway came out number 1. Australia came out number 1 in some areas and stuff, but overall the UK came out 4th. In terms of access, believe it or not, it was 4th as well. So, but in terms of outcomes, it wasn't doing very well at all. And I think there's an element of obviously comparing how that works in different healthcare systems. So typically the Norwegian, Scandinavian ones, they have a much higher tax burden that goes towards the healthcare delivery. So they pay a lot more of their tax money to pay for healthcare. The Australians often have an element of copay. So part of it's subsidized, part of it is paid for by patients and stuff. And that seems to be the hybrid model that seems to have the most effectiveness when basically you need more resources, long and short of it. But the interesting thing I think also worth thinking about is, I asked the question about, could private healthcare work in the UK? We are seeing the increased proliferation of private companies delivering private general practice.
Yeah, absolutely. And I think so. It's interesting, isn't it? So these larger companies like Babylon, like Centene,
Mm-hmm.
they appear to be exiting the market. And I guess what they have done is a little bit different to what more traditional
Mm-hmm.
private practice has done. So I guess they've been sort of trying to deliver the whole thing, and kind of participating in NHS delivery,
Mm-hmm.
essentially. Whereas I think the more tried and tested traditional private companies have been doing more kind of supplementing, supporting NHS delivery. So,
Mm-hmm.
if you want your hip doing a little bit quicker, you want maybe nicer food, nicer customer service, then you can go to one of the private hospitals to have that done, a little
Mm-hmm.
bit more quicker. Maybe you have a nicer experience of
Mm-hmm.
it compared to your NHS hospital. If you want a GP that's going to give you 30 minutes, an hour, then you might go and see a private GP, for example. So they think traditionally the private providers, in my mind, have been doing something sort of different and additional
Mm-hmm.
to the NHS, rather than trying to kind of deliver NHS services, which I think
Mm-hmm.
is a distinction, I think. I don't know if you've noticed that.
I've definitely seen the proliferation of those services. I remember you and I went down to YouTube and we were hearing everybody else talking as everybody introduced themselves. Every single person, apart from me and you,
Yeah.
basically said, "I'm also a private GP." So it seems to me a massive proliferation of people engaging in that kind of workforce and stuff. I guess, like you said, it also raises the question of, is private healthcare something that's beneficial? I think there is certain situations where it can be really useful. Like you said, it's more that transactional type of healthcare. It's
Mm.
where you're paying for a particular service. So, if you're paying for access to a scan or paying for a specific operation. I wonder how well it works when it's more longitudinal care in terms of ongoing aspects and stuff. Often we talk about the fact that general practice, the average patient has about 8 appointments per year. but actually it's funded to only provide about 3 or 4 per year. And how does that make the model work? Well, actually, in a private general practice model, you pay for every single contact, you pay for every blood test, you pay for absolutely every single part that you do, and you get the service commensurate based on that payment. Is it equivocal? So interesting. Speaking to some people who do work at private GPs, they often say that actually it's not as balancing as people think. Probably they have to charge more just to make the ends meet, and that says something about the value possibly of healthcare itself. And I think you made a really interesting point when we were discussing this, actually, that stuck in my head, that when it comes down to patients' access of private healthcare, generally speaking, the people that can access private healthcare are the fitter individuals, the healthier individuals, because those that are more unwell may not have the capabilities and the resources to pay for private healthcare.
Yeah.
And is it that whole inequalities, the whole, the name's gone from me, the triangle, what you call it? Health inequality.
Maslow's hierarchy of needs.
No, the other one. No.
Inverse care law.
That's the one, inverse care law.
Yeah.
That's what I was thinking, upside down. Inverse care law. Is it the inverse care law at its exemplary elements and stuff? So I've done a lot of talking there, Andy. Go for it.
I think it contributes to the inverse care law. I was just going to back up a little bit, Gandhi, because I think you said something interesting about the transactional nature of private healthcare. So I think that was really interesting, actually, because I think I would suggest it is easier to manage risk in delivering healthcare when you get paid for, for the item of service that you deliver. If you do a blood test, you get paid for it. If you do a consultation, you get paid for it. I think it's easier to manage your workforce. You just pull in the work for the work that you have. You pay people for doing the work. If the work isn't there, then you can not pay the people. I think it's easier to manage. I think where it's harder is when you're managing these population budgets, like a general practice budget, where you just paid for managing the population and you have to take some of the risk for the amount of care and the type of care that's going to be delivered. I think that's a lot more difficult. I think that's where, if I was running a private company, I'd perhaps be more sheepish about getting involved with that than I would the more transactional elements. So I think it's interesting. You were beginning to make a point about, I think we were beginning to move into those more kind of areas of principles and ideals around healthcare, which I think is a really interesting place to go when we're talking about private healthcare, because I think it's where a lot of people in the UK start to think and start to go with that. And yeah, it's largely, wealthy people who can afford private healthcare, I guess, because it's not cheap. And I guess you think about why, the NHS is there. Why would people, access it at all? And I guess people are getting, there may be more, Gandhi, but I guess they feel they're getting seen more quickly because they're paying for it. They may feel they've got a bit more choice in terms of what they get, when they're seen, where they're seen, who sees them, is the appointment convenient. They might also get access to a wider range of things. You can probably pay for things which you wouldn't necessarily be eligible for on the NHS as well, in terms of imaging, in terms of potential treatments and so forth. So the range of what's available is bigger as well. And I guess people may get a better customer service experience. So I've joked a few times about, you get better food or, things like that. But people don't like NHS hospital food sometimes, and if you're in a position to pay, then maybe pay for that. I suppose the final one that we've got on the Google Doc show notes is quality ? It's largely the same. It's often the same people, isn't it? Delivering the care privately. So I think that's potentially less different than some of those other elements that we've described. But why do you think patients do private healthcare? Is there anything that we've not mentioned there, Gandhi?
No, I think you're right. I think those are most of the drivers. It's about access, it's about options, and it's about service. Those are the three things, so access and the convenience of access that comes with it, options in terms of the wider variety of potential options, because actually working for the NHS, we are, we work within guidance, as in evidence-based guidance. Important to know, a lot of that evidence-based guidance is provided by NICE, who do factor in cost into their decisions. So that does have an impact in terms of the types of treatments that are recommended, because those are the guidance we're often recommended to follow and things. So it was access, it was options, and it was, what was the third one? I said
Wow,
before.
service.
Service. Yeah, well,
Customer
yeah,
service.
service, you know, customer,
Yeah.
and you know, it can be really interesting. We are seeing more private providers supporting access to the NHS, particularly in terms of clearing the backlog. I know that when I had to have my foot operated on, I went to one of the local private providers under the NHS to have my operation done and my aftercare done, because that was at the time, you know, one of the additional providers and stuff. I only went there because it was the one that I could make, if I'm being honest, because they offered appointments at the weekend, which obviously the fact I was working throughout the week, it did make it more convenient, but it was still under the NHS that was provided for. Interestingly, I saw some recent stuff around the fact that when you look at the healthcare budget, almost double the amount of money goes to private healthcare providers than currently goes to general practice. Now,
Hmm.
important to recognize that a lot of private healthcare providers are doing more expensive work per se. So obviously, an operation is considering more expensive than, you know, the amount of money offered to provide healthcare for a smaller size population and that kind of things. But it does use resources and stuff,
Hmm.
and it is a different level of service compared to when I've had, you know, other healthcare needs and stuff. There was a definite different sheen on it, shall we say, in terms of what was offered.
So Gandhi,
Hmm.
let's see if we can get a little bit controversial, because we're quite
Okay.
measured, aren't we? So let's talk about some of the kind of principles behind some of
Hmm.
this. I'm gonna throw some things at you, and you can, you know, agree or defend, you know, whether. But I mean, so if people are paying, you know, privately, you know,
Hmm.
don't they get to kind of jump the queue to a certain degree? You know, people with the means to pay get what they need quicker and more easily.
Hmm.
And, you know, is that right? Is it justifiable? People will say that.
That's the mechanism that seems to happen, is it? And the hope with that is that then that frees up the capacity within the healthcare provider elements of the NHS to therefore mean that those who need that healthcare then get that theoretically a bit sooner, because you've creamed off the ones that can go somewhere else, isn't it? The
Oh,
reality is,
I like this,
yeah,
Candy, because we're kind of devil's advocate here, aren't you? But you know,
yeah,
but I would say there's a finite pool of workforce, you know, in the
yeah,
UK. You know, the NHS is struggling to
hmm,
fill vacant positions at all levels: consultants, nurses,
hmm,
porters, you know, everyone. And actually, you know, the private healthcare providers, basically, they're just taking the existing staff, you know,
yeah,
and shifting the work that they could have done for the NHS into the private sector. Okay, they
hmm,
might be being paid enough to motivate them to actually work, you know, at the weekend or additional hours. But, you know, the NHS, you know, could do that. They might be motivated to work in the NHS if they weren't getting paid in the private sector to do that. So actually, that they are jumping the queue, and you know, and
hmm,
there isn't the workforce there to backfill the NHS to see everybody else.
hmm.
I would argue, but is there any defense of that?
Well, I guess it raises the question, if you've invested in yourself to provide those resources to keep yourself in that situation where if something was bad to happen, that you could fix that quicker and then potentially get back to what your normal life was. Is that also wrong? Is that prudent planning? Is that, you know, effective creation of your life that you'd be able to do and stuff? I can see it from both sides. I think when you talk about population delivery, I think that's where it gets a bit more nebulous and a bit more challenging to, you know, justify in some ways, unless, of course, we're just more transparent around the fact that actually we need to look at the healthcare budgets themselves and what is actually being provided for, and have that honest debate about whether it's working.
Yeah, it's interesting. I mean, at a personal level, so as you say, people say, "Well, I've saved my money. I didn't spend it on X,
Mhm.
Y, and Z, and I worked hard. You know, why can't
Mm.
I pay? You know, if I want to for this additional health, you know, this additional healthcare, you know, and who are we to tell people they can't do that? But
Mhm.
but it looks different, doesn't it? If you're looking at managing the population's health, and you know,
Mhm.
you would have a different perspective and say, well, actually, that person's really fortunate that they've been in a position to receive the education, you know,
Mhm.
and the good health and good grace to be in that position to afford the healthcare, and other people aren't so fortunate, and actually we could be supporting them. It becomes very
Mhm.
quickly quite an ideological discussion, doesn't it? Really,
Yep.
about how you see the world. However, so I would say, but you know, just continuing the line from before. So I guess, yeah, it might pull people away from the NHS and the work, you know, the workforce, but
Mhm.
But then people might say, well, actually, in the medium to long term, maybe it does pull more investment into the healthcare sector. It may be, Spire. They've built a new private hospital, on the outskirts of Nottingham, that's new, and they've paid for that, or their investors, and that's new physical space that the government hasn't paid for, that's seeing patients, that's been paid for by investors in Spire, for example. And and actually maybe not all of the workforce does come from the NHS. Maybe they bring in international workforce, and actually the number of workers can grow to meet the demand more slowly, so maybe it isn't that bad. It's complicated, isn't it? I was wondering if we'd be more controversial, but I guess we're sort of describing the situation and backing away from those ideological things. Gandhi, the other thing which people might not automatically think about is the distortion of case mix. So it's kind of part of that inequalities thing, but there is danger that those people who choose to seek private healthcare are potentially those people who are fitter, more able. That actually correlates. People who are wealthier actually have lower health needs. We know about that. They have fewer comorbid conditions. They're potentially the more simple patients, that are potentially being dealt with in the private healthcare sector. And what that does to the case mix in the NHS is it can mean that actually, your local NHS hospital, is doing the hip replacements on the people with multiple other health conditions who are really, really complicated, frail, need a lot of aftercare management in the hospital, longer stays, actually more expensive to deal with, and actually that can potentially increase, the burden on the NHS because the case mix has become a lot more challenging. So it's complicated.
It is, definitely. And I think that's a really interesting point that you make. It's also probably a good place for us to ask the audience what they think and what their thoughts are in terms of healthcare, private provision, and all that kind of stuff as well. And I would love to know what people are thinking down below. So if you could let us know, show notes, that kind of stuff as well. You can also use our SpeakPipe thing, and the link to that will also be down there as well if you want to add in your comments. And maybe this is something we need to have a bigger debate on, Andy. I don't know. What do you think?
Maybe it'd be great to bring in some other voices, wouldn't it? It's difficult. It's controversial. That's why some people sometimes don't like to talk about it, but needn't be. We're having a very well-mannered conversation about it at the moment. The other perspective, just to think about, I'm just thinking about the government ICB perspective as well.
Okay.
Because I think something that would make me pull my hair out if I was at the ICB would be dealing with lots of individual contractors, like the general practice sector, lots of small contractors, getting them to do anything in a coordinated way, I would see as potentially difficult. They'll all have their own needs, their own quirks, their own reasons for wanting or not wanting to, engage with certain things, and that's going to be very complicated to manage. It's going to take a lot of resources to manage that. Wouldn't it be great if there was just one big provider, that I could discuss things with, maybe a bit like the NHS Trust, providing hospital care, but for general practice. I can see why ICBs may see or have seen that as attractive, I guess. But then I suppose if that provider pulls out all at once, you've got, rather than having, a small headache of one of the individual GP surgeries handing back their contract, you've got the massive headache of 53 contracts, potentially being handed back or changing ownership. But I think that's probably been an incentive from the centre, from government and ICBs to, if not favour larger providers, then, be neutral about it. So that's just another interesting perspective to add.
Definitely.
So but so go on, Gandhi, what were you going to say?
Well, I was going to say it's probably a good point to, like I said, see what other people are thinking. So do let us know down below in terms of what you are thinking. You've heard mine and Andy's thoughts. I guess we have covered this in a couple of other episodes in a bit more detail. So if you did want to check those out, do feel free to go have a look at them. In particular, for the colleagues out there, our peers and stuff, GPs, if you want to go check out the episode about the evidence and the guidance about how to deal with private healthcare from a primary care perspective, then do check out this episode right here that's coming up. And as always, we're going to be here to help tech enhance your primary care and learning, and we will catch you in the next episode. And we may do this again, so definitely subscribe so you can find out if we do or not. Catch you later.